Starting with myofunctional appliances, it is a very important aspect of the whole curriculum where we speak about changes in the skeletal pattern of a patient, where we bring the lower jaw ahead or behind. So, starting with the definition, myofunctional appliances they use the facial muscles and the masticating muscles to produce some changes in relation to the teeth or the arches. So this means that these appliances they utilize, eliminate, or guide the forces that are arising from the muscle function, such as facial muscles and masticating muscles, causing tooth eruption and growth in order to alter the skeletal and the dental relationships at the end of the day. So when the myofunctions were removable initially, Tom Graeber, who is the main prominent person in terms of orthopedic appliances, so he classified these myofunctional appliances into three groups. So group A, B, and C. Group A are teeth supported appliances such as Catalan appliances, inclined appliances, etc. Group B are teeth slash tissue supported appliances such as activator, bionator, etc. Group C is vestibular position appliances. So technically, they do not use tooth support compared to use the whole vestibule as a support. For example, such as Frankel appliances and lip bumper, which work on the principle of force application or elimination. So it can be classified based on if it's removable or fixed, where removable functional appliances, for example, activator, bionator, flanker, monoblock, twin block, etc. So they can be removed or placed back into the oral cavity at the will of the patient. So the next is the fixed appliances, which are non-compliance appliances. Removable appliances are also called as compliance appliances. So fixed functional appliances. So these appliances have the advantage that they require less of patient's compliance. So this technically enables the clinician to have a very good concurrent fixed appliance therapy, so the patient by themselves cannot remove these appliances and offer an advantage of 24 hours. So this means that they are subjected to force of mastication with an associated heightened risk of fatigue and breakage. So technically, a good amount of success rate can be achieved using these fixed function appliances. So other mode of classification is via rigidity of the appliances or its flexibility of appliances. So talking about rigid fixed functional appliances such as Herbst mandibular anterior repositioning device, which is short for MARA. So, meaning that these appliances they'll posture the mandible into one particular fixed position without any flexibility in the system. That means they are completely rigid; they cannot be altered or moved. So, it is not exclusively used prior to a comprehensive fixed appliance, so it is used in a two-phase approach. So fixed functional appliances for flexible such as Eureka springs, forces fatigue resistant devices, Jasper jumpers, so all these encompass those that have a component such as a spring. So this spring allows some flexibility in the system of these appliances. So when the mandible is posted forward, it is used together with the fixed appliances in one comprehensive phase of treatment, unlike the rigid fixed appliances, which is done in two-phase approach. Coming to the indications and some design consideration of functional appliances. So technically there are various indications where most common indication is to correct class 2 malnutrition, of them being the most common that you would see. However, it is also given in class 3 cases, treatment of class 3 malocclusion, where some different version of the same appliances can be used to correct a class 3 malocclusion. So it has been suggested that the treatment time should not be less than 12 months. So follow-up of retention period of is of same length and before the commencement of second phase treatment. So to achieve good successful fixed appliance therapy or functional appliance therapy, it is important to assess the maturity status to get the puberty growth spurt. So if the growth spurt is yet to happen or is in progress, so there are following tools that are used to understand how much growth is left. First is the standing height measurement. So they involve standing height at 4 monthly intervals from 9 years to 9 years of age. So at this point of time, each height can be correlated to one particular stage of maturity. And there are hand wrist radiographs where we technically use the Fishman skeletal maturity index um, indicator, which relates to one particular bone knee changes that are occurring in your hand wrist to be compared to your maturation status. So cervical vertebral maturation status is taken from the cervical from the cephalogram, where the cervical spine or the atlas and its vertebrae are seen for the maturity or the stages of the bone development. Apart from the secondary sexual characters can also be used. So this removal will go on speaking in terms of some of the orthopedic appliances such as the activator. So if you can see, this whole block is an acrylic block. Originally, the appliance was made with vulcanite, which is an hardened rubber that both the blocks are joined together. So it was developed by Anderson in 1908, and subsequently it was actually popularized as handrest in Hopple appliances. So technically, the original appliances was rigid, and if you can see here that it is taking a tooth bone, it is supported tooth bone, and it's loose to fit. You cannot appreciate that there is an involvement of the tissue here. So it was quite bulky with the acrylic blocks covering both the arches, the palate, and also it was constructed to particularly hold the mandible in the protrusive position. Though originally it was planned to be as a retainer, it showed good changes in the mandibular condyle. Seeing the shortcomings of activator, Wilhelm Balters developed an activator kind of a block which had less bulk. So these, if you can see, majority of the chunk of acrylic is removed. So these appliances were known as bioneters. So the upper and the lower components of the bioneter were connected by a wire, facilitating an incremental activation of the appliance. So if you can see the wire bending here, that is present on the buccal and the facial surfaces of the tooth, it is majorly meant to prevent excessive application of the force by the cheeks and the facial muscles. Coming to the appliances, the Frankel appliances developed by Dr. Rolf Frankel. So technically, during this time, the majority of the philosophy turned to the fact that malocclusion was created due to the differences in the muscular forces. So to prevent excessive muscular forces acting on the dentition to allow it to naturally conform to its natural state. We Frankel's principle in this case was to eliminate the forces that were coming from the cheek musculature to the labial musculature. So if you can see here, particularly this acrylic block prevents the buccal musculature to that is acting excessively on the arch. So here, a lower lip bumper is given in this case, and this is a Frankel functional regulator too. So he believed that more room should be given to the tongue to allow certain tongue exercises to be undertaken. So functional appliances paired up with habitual tongue thrusting breaking appliances help to achieve a better control in patients. So monoblock appliances, it was originally given prior to all the appliances that we have spoken before. So it was developed by Per Robin in 1902. So Per Robin in his the syndromic cases where it's named after him, which is Per Robin syndrome. So where you can see a very particularly protrude mandible. So this monoblock appliance, was also originally made of a vulcanite bite jumping appliance. Vulcanite is a hardened rubber. So it was particularly used to position the mandible in a forward position in class 2 malocclusion where the mandible was deficient. So coming to some of the fixed functional appliances, this is a Herbst appliances in 1909. If you can see, that is a uh, telescopic appliances. If you can see that there is a telescope kind of mechanism that keeps the mandible in a protruded portion. So later it was popularized by Patches in 1979 till his time in Herbst during 1909. The concept of these appliances were not taken well by the authorities. So you can see that the mandible is maintained in a protruded pattern or position, which can be either banded or casted or used as an acrylic splint or cantilever by jumper. This is a forces fatigue resistant device similar to that design. There is no telescope, but it is a spring action mechanism where it is given along with a fixed appliance. If you can see here, it is attached to the molar band and to the canine distal of the canine. Coming to the construction of the clinical management of the functional appliances, for impressions, you should take very good quality of argent impressions that has no voids, that are poured immediately after that they are taken, so there is no difference. Is so that you have a high accuracy. So a good quality impressions for upper and lower dental arches, consisting of both good quality of dental arch and soft tissue information. So uh, so that you can create a very good sound appliance that can have a successful functional treatment. So coming to bite registration is taken when the mandible is in its most protruded or retrograde in case of class C malocclusion. So without causing any discomfort to the patient, you have to take a good bite registration, since this becomes the base of the whole appliance, and the accuracy of the treatment and the appliance depends on this part. So fitting of appliance, it should be a snap fit, there should be no sharp points, it should be polished well, there should be no since the compliance majorly depends on such factors. So for the follow-up appointments, there should be given of 6 to 8 weeks. Um, so you should check for their speech, the way they are adapting to the plans, how much function that they are doing with the plans, how much activity that has shown. Technically, you would like to see a good amount of facial and skeletal changes with some amount of dental changes, like opening of lateral open bite in some of the cases. So, uh, following a good clinical management of these functional appliances will give you a good line of treatment, treatment in your cases. You could get a good